Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Let's go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need. We've got a question from Megan for feline showing signs of stomatitis under 12 months old. Is there any benefit of waiting before doing full mouth extractions to see if it will improve with digital home care? And that's a multifaceted question. It's a great question. And the first thing we need to take into consideration is this stomatitis. You've got a patient under 12 months of age, and there are two very common conditions that can be confused with feline hyperplastic gingivostomatitis, and those are feline chronic gingivostomatitis, and those are, as we will show in the keynote here, in some images. So this is the first of those. This is, as I tried to meld the names, feline hyperplastic gingivitis. And this condition occurs generally recognized around 6 months of age. It needs to be differentiated from its very similar condition where we have eruption of the tooth and a little bit of hyperplastic tissue at the time of eruption. So we want to make sure we're not dealing with pericoronitis, which is due to eruption and a little bit of inflammation of that tooth coming through the gum. But if it's persistent, if it's 6 months, you recheck in a couple weeks, it's still there, and it's that pronounced like it is in that image, where we actually have that tissue growing over the crown of the tooth, then that's pretty consistent with that condition. There's also some, and that looks, you just take a glance at that, you might think, oh, that's stomatitis. Well, it's very inflamed tissue, and when you biopsy that, it might come back stomatitis, because when they're looking at that from a pathology standpoint, they're looking at the plasma cell. And if there's plasma cells in there, they're going to call it stomatitis if it's from a cat. So you can't go by that in any histopath. You have to look at the whole patient. This is another condition, very similar, juvenile onset periodontitis. And this can occur and looks a lot like stomatitis, but it's not stomatitis. This is definitive for feline chronic gingivostomatitis. This is caudal mucositis. If you look past the maxillary arcade there, the inflammation in that caudal mucosa, that is pathognomonic for stomatitis. And if you have that, the only recommendation is full mouth extractions or caudal mouth extractions in very few instances, and we have a question regarding that coming up, so we'll talk about that in just a second. But you have to be able, in response to this question, at 12 months of age, you have to be able to differentiate those. And back to the benefit of waiting, if you can document that, as soon as that's documented, the recommendation for full mouth extractions is on the table, either by referral, or if you're extremely experienced in veterinary extractions, then you certainly could handle these in your own practice. But I say very experienced. That means you want to have a lot of experience doing flaps, surgical extractions in cats, and have had wet labs that are focused on technique and focused on you creating the least offensive outcome for that patient. So if you've not done that before and you've only done a couple of extractions for a couple of years in cats here and there, this is not a case for you. There are a lot of situations where you have tooth resorption and you have other problems that need to be addressed. You've got the aftercare for 70 to 80% of these that are refractory to treatment. So you definitely want to make sure that you've got a lot of support there, and referral is your best option in probably 95% of the cases of individuals that come to our courses, wet labs. So we talk to them directly. We know that that's the case, and these are tough cases, very tough. So you have to really consider, am I going to be helping this patient or making it worse? And I've got some information on some updates on these refractory cases, so I want to show you that here in a second. But the next question is, do we always extract canines, or is it case-by-case basis? So let me show you this image. This is an image of a case where only the caudal cheek teeth were extracted, all 4 canines were left. And so this is the outcome in a lot of those cases. And the incisors, plus or minus the incisors, are extracted at that time, depending on inflammation. I can't recall if the incisors were extracted here, but it looks like they were, because unless that image, the top of that image shows them, pretty sure they're not there. But anyway, you can do this initially. I have had a handful of these cases that we've chosen to do that over the years, where the owner wants to not extract the canines, and let me stress that there is no inflammation around the canines or incisors, either in the attached gingiva or the unattached gingiva. If that's the case, there is no option. It's got to be full mouth extractions if you have caudal mucositis and you have also the arcades affected canine teeth being included with that. Very good. So let me go over some of the updates in refractory cases. And Boaz RZ is the head researcher at UC Davis, and he has been looking at regenerative medicine for treating these for quite some time. Regenerative medicine being autologous stem cells from the patient. And they have just gotten sponsorship in the last 18 months to 2 years for a company who is going to be doing some of the production of the diagnostic materials that are needed to make sure that we're using the correct subset of cases that don't respond to full mouth extractions in order to treat with stem cells, and also the process patented for stem cell production. And that has they have gotten the approval for all of that, and so that's in full-blown activity mode right now. So they are Gallant Therapeutics is the one that's doing some more research on this, and they should have some definitive answers as far as the cause of stomatitis here within the next 18 months to 2 years to document their findings. So let me go over really quickly what their findings are as far as the cause. This is probably of interest to everyone. So we do know that there's a strong evidence based on the research that Boaz has done, and this is updated yesterday. I had an email conversation with him yesterday on updates on this. So they have in the past identified what they call a Puma foamy virus, and if we have that present in conjunction with calicivirus, which appears to be the primary cause in inciting an autoimmune inflammatory condition in these cats. So calici causes the inflammatory autoimmune condition, And if the Puma foamy virus is present, then that in itself, with Khaleesi, make the stem cell treatment for the refractory cases not an option as it appears now, because those cases do not respond in their experience to stem cell therapy. Cases that do not have the foamy virus, and also they're looking at immunological subsets as well that they're keying, especially in this research, to determine which of these patients would actually benefit from stem cells, and then they will be able to provide stem cells to cure these patients that have the correct subsets and don't have the foamy virus. So it's really exciting from that standpoint. So we're so happy that Boaz RZ and his team at UC Davis are up on this and have been putting all their effort into this for several years, because this really impacts these patients that suffer for quite some time. So we're so happy with that. I must stress that any treatment that we're talking about, any treatment that we talked about in this actual case, the treatment with the stem cells I just mentioned, none of that is applied to patients that have teeth, because the autoimmune is due to the plaque on the teeth. If the teeth aren't there, none of those things work. Extractions, full mouth extractions in 99+% of the cases is the first and only recommendation that you should have to a patient that walks in and you recognize this problem. You can use medications to help them, and we'll talk about that in a few minutes with some of the questions that we had, but there's no treatment that will help long-term without full mouth extraction. So I want to make that clear. Janie Rodriguez Dufresne, what are the recommendations for these cats as far as the meds before we get them in for extractions and referral? And that's a great question, Janie. A lot of these cats you're not going to be able to do day one. As we talked about CRIs, we in our practice get them the same day, but you as the practitioner are going to see these, you're going to recognize them. You can't do them the same day, or you can't get referral the same day. So we want to do something that's going to help these patients. The biggest thing that does help is prednisolone, and preferably oral prednisolone at reasonable doses, 1 to 2 milligrams per kilogram BID to start, to really impact that inflammation, really impact their eating if they're not eating, and really impact their discomfort and inflammation in general, and then decrease that into an every other day regimen. You can add anything to that. Gabapentin is a staple for this because it's a chronic, it's for chronic pain. We don't know exactly how that works, but from that standpoint for oral pain, but we do feel that it decreases the release from the presynaptic membrane of substance P and some other substances that are causing more frequent and more intense pain to reach the cortex from the brainstem. So from that standpoint, gabapentin, prednisolone, orally. We don't like to use depots. Sometimes you have to, but it's not something you want to use multiple times. If you have to get this patient where it's comfortable and administration is an issue, then you need to consider that, but that's a very last resort. Other analgesics we've discussed. So that would be the recommendation. And once those meds start, once you see that patient for the first time, get these guys started. That's an action step immediately to get these guys started on the road, to get to somebody, whether it be you or referral, to get those extractions done. Melinda, are there any ways to avoid ocular trauma during nerve blocks? And we'll talk about nerve blocks specifically a little more in some of the cases as we go through. But in cats, the recommendation is to do the infraorbital block, just like you do in dogs for the rostral premolars and the incisors in the canine. You don't go all the way back. You just go right into the foramen, just barely into the foramen. You don't do the caudal maxillary block like we do in dogs, because that'll put you right at the orbit. and knowing the right technique. Have you used Nocita in replacing bupivacaine in cats? And there is very little information, even with my specialty colleagues, on whether this is something that we want to use. Very expensive, and it is there's not a lot of proven benefit from this. I have one colleague, John Huff, who I know uses it in his practice, and he is very satisfied with it. He works in a multiple doctor specialty practice, and they use it, and it's very effective in his hands, but most of my colleagues do not on the specialty level, so we certainly can't recommend it. I see in the extraction video you use an air syringe to clear blood. Have you had any concerns about causing embolus on this exposed bone? And this is from Cathal Rafferty. And Cathal, when we use the air-water syringe or the air, we do not, we use the air-water obviously with our burr, and that's to cool the burr. When we use the air-water syringe, we don't directly put air up into and toward the bone. We want to direct it away. The chances of air embolus are probably little to none, but it has occurred in humans. It has occurred in veterinary patients, so you do want to be careful. With the more common problem would be where we have emphysema, where we get collection of air that traverses the tissue planes and ends up generally going dorsal because air is light, so it goes through the tissue planes and ends up on the top of the head. Can go to the neck as well, and you get that crinkly sound when you pet the patient. You definitely want to let the owner know if you do encounter that. It's very infrequent. We do a lot of cases in our practice, and we almost never, and they're all dentistry, and we almost never see that, but when we do, we make sure we let the owner know. It's just a side effect complication that's untoward in dentistry, and it's not a big deal. It'll resolve in a couple days. In the neck, you got to be a little bit more discerning because that could certainly be a tracheal tear. So you want to make sure that you're aware of that and do a little bit more reading on that just to make sure you're not doing anything that might involve tracheal tears, especially in cats. Amelia Jane, why do you no longer use mental foramen nerve block? And that is because there is a really small foramen. You have to use a 25 gauge needle. It's a little bit more difficult. You're putting that agent into a very small space. There has been research done by James Anthony a while back that showed some damage to the nerve and the vasculature from that, although it seems to be minor. It's so much easier to do an extraoral mandibular nerve block on dogs and cats. And from the standpoint, the next question always is, what about biting their tongue? Doesn't exist if the practice is, or if the patient is recovered properly. And by recovered properly, what I mean is that they are sternal before they're left unattended. And if you use our light anesthetic techniques, that will not be a problem, because a lot of those patients wake up on the table, they're sternal, they may be standing before they're cleaned up and put in the cage, which is less than 5 minutes. But that's another discussion, and we'll probably touch on that in one of the later workshops. But with that being said, we've got a lot of evidence that we just don't have that as a problem. I'm sorry, I lost my place here. We don't have that as a problem. It's never happened in our hands, and it's a matter of having that head in lateral recumbency, tongue falls out, dog or cat chews the tongue, and with or without nerve blocks. But if they're recovered, that's fine. Now, for big cats, for my veterinary dental colleagues that are doing big cats, you can't recover those. And they've got that huge, long tongue in lions and leopards and pumas and whatever big cats you're working on, and that hangs out, and you don't want to be in recovery with that cat waiting for it to wake up, right? So they do not do the caudal mandibular block in the large cats in zoos and things like that because of that. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.